What the hell just happened? What the hell? Good evening, everybody. My name is George Nicholson. Welcome to our ASHRAE chapter meeting. RH and the spread of COVID. We're going to start with the Code of Ethics. In this and all other ASHRAE meetings, we will act with honesty, fairness, courtesy, competence, inclusiveness, and respect for others, which exemplify our core values of excellence, commitment, integrity, collaboration, volunteerism, and diversity. We shall avoid all or real perceived conflicts of interest. So I'd like to welcome everybody to our technical session, which we are doing in a joint session with the Miami chapter. I'm going to hand over to President Victoria Garcia Massimo.
Hi all, thank you so much for connecting today, and thank you Caricom for inviting us to this chapter. We really appreciate it, and hopefully it'll be a very interesting topic, and especially with the pandemic we're living, so it's all going to be very useful information. Thank you for the invitation, Kaden.
Hello everyone, my name is Julia Lewis. I'm from the Miami chapter. I'm the CPPC chair. I also want to thank Caricom for inviting us to part of this meeting. And I would like to introduce our speaker. Our speaker is Dr. Stephanie Taylor. She received her MD from Harvard Medical School in Boston, Massachusetts, and subsequently practiced pediatric oncology and did research in several mechanisms. She has been very alarmed by the high number of patients acquiring infections in the inpatient treatment, and she became determined to better understand the role of built environment and patient outcomes. To learn about the design and management of buildings, she obtained her master's in architecture at Nordic University in Pennsylvania. Dr. Turner now works as an international and research leader, designing and operating hospitals and other commercial buildings. Her unique approach is to use health data of building occupants to determine which indoor air and design characteristics support or harm human health. She has published in Nature, Science, and other peer-reviewed journals. Is a distinguished lecturer for ASHRAE and an earlier contributor to Engineered Systems Medicine. She also sits on the Epidemic Task Force formed by ASHRAE to deal with COVID-19. Thank you, Dr. Taylor, for being here.
Dr. Taylor, you're self-muted, I believe. Now I have you good.
Thanks. So also, where is the share screen button? Can you help me share my screen, please? Ah, great.
That's good. I can see
Okay,
it.
great. Well, so hello, everybody. Whoa, something just happened. You get to see my son there. Sorry. Darn it.
All right, that
Hazards.
happened to me as well.
What?
That happened to me as well.
How did, I don't know. Oh, there it is. Okay. Well, I'm really honored to be here. Despite all of the uncertainties with this this pandemic, it has definitely opened up a new a window and an opportunity for everyone who's in the building industry. So I'm really excited to, as a physician and then having gone into architecture and engineering later in my life, I'm really excited to share with you the findings from my research and to encourage everybody to realize how important your work is. And so, as you can see from the title, engineers are the physicians of the future. And I really believe that. I think the well-being of public health is actually in your hands. So what that means is, I hope everybody listening to this will go forth and learn more about biology and about medicine and about the relationship of human beings in their environment. So I'm primarily in my clinical work, I'm a pediatric oncologist, and then I went back to school, got my master's in architecture because I realized I knew nothing about buildings. And I also work a lot with ASHRAE, and I'm also working now to collect data on health in the indoor environment. So tonight, in the next 40 minutes, I'd like to talk to you about three sort of subjects. The opportunity that COVID-19 has opened up to all of us in the building industry. I'd like to share with you some studies, and then I look forward to opening up a discussion with a lot of questions about how we move forward given these new priorities for buildings. But before I get into the research, I just wanted to share a little bit with you about how I came to be here as a physician. So this is me when I was in medical school in the 1980s, and I decided I wanted an adventure. So I went to Papua New Guinea and worked there for about 4 months in setting up clinics in these villages. You could see my form of transportation was a dugout canoe, and I was having a lot of fun. And this was the hospital that I was stationed out of. It was the Wewak General Hospital. And that's me in the operating room. You can see I have flip-flops on my feet. The surgical nurse was not wearing gloves. And in the middle, that you see the men's tuberculosis ward. And you can see that the families would help take care of the children. And I was really surprised because to me, these conditions did not look as hygienic as I was used to in the US. However, these patients did very well. They didn't get extra infections from the hospital environment, and they went home pretty much when we thought they would. However, back in the US, infections that people get from the hospital environment during their hospitalization is one of the leading causes of death. Hospital statistics say that anywhere from 4 to 7% of patients acquire an infection from their hospitalization. It's actually worse than that. However, the reporting is very non-transparent because hospitals are penalized for these infections. But the take-home message is that in this country, with more hygienic looking facilities, we have a bigger problem with infections. So when I thought about this is back to the 1980s when I was in medical school. And the gentleman you see in the middle, Dr. Folkman, was an absolutely brilliant man and a wonderful mentor. I worked with him for 6 years, and we were doing research on how tumors draw blood vessels into their center so they can then grow further. And one night I realized that a lot of our research mice were dying. The study mice were dying, the control mice were dying. I called Dr. Folkman up in the middle of the night. I said, something's going wrong. And he got out of bed and he came to the hospital, and we scrubbed the research operating down from top to bottom. And he told me, never ever underestimate the power of the environment in health outcomes. And it made a big impression on me. So speaking of our environment, as human beings, we spend most of our time indoors. I live in northern Vermont. It's really pretty here, a lot of mountains, and I like to hike and bicycle and ski and all of that stuff, but I'm still indoors more than I'm outside. And if you look at the history of the human environment over time, you know, a very long time ago, our dwellings had a lot of communication with outdoor soil and air and water, plant material. And our building technology became more and more sophisticated. And now in 2020, especially after the energy crisis of the 1970s and 80s, we started, at least in this country, sealing up our buildings. The indoor environment is drier. It's generally quite comfortable in terms of the temperature. Often the windows are sealed. So that clearly the building materials and the building technology has become very sophisticated, as well as our sanitation. However, sort of alarmingly and somewhat mysteriously, many disease categories have also been on the increase. So clearly now we're dealing with the COVID-19, but in addition to infectious diseases, we have more inflammatory-based diseases, we have more allergies. And even though this is not a statistical analysis in front of you, we're generally seeing a trend that as we tighten up our buildings, we're seeing more of certain diseases. So COVID-19, it's obviously not the first pandemic, and it's not going to be the last. Interestingly, if you go all the way back to the 1300s and you look at the bubonic plague or the Black Death caused by Yersinia pestis, people thought that the transmission vector was a rat, and they thought that the fleas on rats were the primary cause of the spread of the bubonic plague. Interestingly, about 2 years ago in 2018, some of the corpses from the London area were dug up, and they were reanalyzed with these newer evaluation techniques that I'll tell you about. And what the microbiologists have concluded is that the primary form of spread of the Black Death was in fact not the fleas on rats, but it was a pneumonic transmission pattern. So it was spread more through the air than through an insect vector. The Spanish influenza we know was airborne primarily, and now with COVID-19, even though the primary transmission route has been a topic of debate, is it contact, is it large droplet spread, is it small droplet spread? And more it's looking like small droplet aerosolization over distances is the most impactful transmission vector. And in fact, this virus has mutated, so it's different from other coronaviruses. Coronaviruses cause the common cold, they cause SARS, MERS, but this SARS-CoV-2 has mutated in such a way that it attaches deeply to our lungs, and we've never seen this virus before. We've never seen this strain, so we don't have immunological defenses to protect us. But I don't want to just talk to you about COVID-19. As I said before, this isn't the first pandemic. It's not going to be the last, and we will get through this. You know, things may be different moving forward, but we're going to get past this. But this CDC map shows clearly that coronaviruses aren't the only microbes or pathogens. Pathogens are the microbes that cause disease that we have to think about. There are diseases that we thought we'd conquered that are coming back, and there are new diseases on the rise. So what this means for all of us in the building industry is that our work is important now, and it's going to be very important in the future as well. So if you want to put it a little bit bluntly, one of my colleagues said, over time, we shape our buildings, then they kill us. So that's Dr. Dickerman. That's kind of an alarming statement. It's not really what we aim to do when we design and operate buildings. And we have to think about, is that true? But accepting the role of the built environment in protecting our health actually has an upside. As we wait for medical professionals to, as you wait for us to develop an effective vaccine and effective treatment, the fact that the built environment has a very important role in either promoting or diminishing the transmission of diseases actually opens up to engineers and architects and facility managers and contractors a whole new way to manage our health. It's very, very, very important. Because after all, why do we have buildings? You know, in the past, a long time ago, we wanted buildings to protect us from rain and snow and floods and earthquakes. And then again, in the 1970s, we really began to focus on energy efficiency. You know, LEED came into being, and clearly energy efficiency continues to be important. COVID-19 has focused us in a very direct way on the role of the building in protecting humans. So how do we know what to do to protect our health? You know, ASHRAE has a lot of guidelines. You know, the data that supports those guidelines is often from the remote past, and it might be hard to see the connection. Thankfully, we have some new tools so we can continue to gather data and do research on how the building actually impacts human health. And I'm going to share a couple of studies with you. So it's kind of exciting actually, because we have a few tools that have given us a completely different vision into how buildings relate to humans. And especially when we're talking about microbes, we have a new set of genetic analysis tools that give us a much more specific vision of how microbes, the good ones and the bad ones, occupy buildings with us. Because if you look out into the room, wherever you are, or you're looking at your computer, hopefully you don't see anything, hopefully you don't see bacteria and viruses floating in the air. If you were to put a petri dish down and let the dust settle into that, and then incubated that petri dish and looked at it under a microscope, you would see some bacteria that would grow in the petri dish. But with the new tools called metagenomics or genetic analysis tools, we've actually uncovered a very vast world of microbes that live indoors with us. And in our buildings, on our bodies, and in our buildings. In our bodies. The ones that live in our bodies we call our microbiome, meaning all the communities. So let's just take a look at an animation that's based on research of how humans interact with microbes. So as I'm talking, and you're all breathing, I hope, little droplets come out of your airways, about 100 microns in diameter, and they carry all the natural bacteria and viruses and particles in your mouth, your nose, your sinuses. As you can see, this engineer is working away. It's a little old school, she's using paper, but you can see that particles from her skin, particles from her nose, this is normal, it's not gross, are coming out, they're landing on the surfaces. You can see that her digestive system is illuminated because we have a lot of bacteria and viruses and particles in our GI tract. And these organisms and particles are landing on surfaces. And then depending on how the air is managed, depending on how turbulent it is, how dry it is, there's communication between surfaces and the air. And then depending on how tightly sealed your building is, there's more or less communication between the indoors and outdoors. So you can see from this that we have a very active exchange with microbes in our built environment. And this slide is, I find, really fascinating. We now know from using these genetic analysis tools that depending on how a building is designed, ventilated, and used, certain microbes, the good ones and the bad ones, will survive. Think about evolution and Darwin, survival of the fittest. The building now is determining through survival of the fittest which organisms are going to survive. So remember, there are good ones and there are bad ones. So we need to figure out how does our design and operation of buildings hopefully select the good microbes, not the ones that are going to make us sick. So so here's the first big study that I was involved in to answer that question. Do indoor factors contribute to infections? So this study took place in a hospital, not because a hospital is medical or anything like that, but a hospital is a great place to do a study on the role of the building on human health, because think about all the data that you're already gathering on the occupants, meaning the patients. So the patient is sort of like this study is like the biomarker of the building. So we're going to view the building through patient outcomes, and in this study, through infections. So this is a study over 13 months where we looked at all of those different parameters that you see listed in 10 patient rooms for 13 months. So temperature, hand hygiene, room pressurization, lighting, carbon dioxide, humidity, room traffic, room air changes, and outdoor air. And the microbiologists were looking at the colonization of the building, but I wanted to see how all of those parameters related to patient infections. So just think about, okay, which ones do you think might be important? I thought hand hygiene would certainly be up at the top of the list. I wasn't quite sure what else might be relating to infections. So we sent all this data off. We had about 400 patient records and 8 million environmental data points. And our statistician came back and said that the most powerful correlation was dry air. So all of you who live in a humid environment, remember, you're probably breathing a sigh of relief. At least I would be. But remember that we have to consider indoor conditions, not outdoor conditions. So our statistician said when the relative humidity in the patient rooms was around 32%, the infection rate was high. And as the relative humidity climbed up over 40%, the infection rate went down. You can see that this is also seasonal. So I thought that we had missed some other important variable. So we got another statistician to go over our data who came back and said, this is an independent variable, meaning that none of the other variables influence this outcome. So I was still skeptical. I'd never thought that dry air could promote infections. So I did another study in a nursing home. And this one is over 4 years. So we looked at infections in the nursing home population. So we looked at respiratory infections, gastrointestinal, urinary tract, eye infections, and skin. And then we correlated the infections with the indoor and outdoor climactic data. And we sent 4 years worth of data off. And these were the results. On the x-axis, on the bottom, you can see the indoor relative humidity. And on the y-axis, you see the average number of infections. And especially remarkable were the respiratory and gastrointestinal infections. And when the relative humidity was between 40 and 60%, we had the lowest rate of infections. Urinary tract infections, the green line, were not related so much to the indoor environment. It was more had to do with mobility and hygiene. The other two categories trended downward. So this nursing home started humidifying after these 4 years were up, and they've had no COVID-19 infections. And about a half a mile down the road is another nursing home that didn't manage their indoor humidity, and they've had one of the highest incidences of infections in our state. I don't have the after humidification results to share with you. We'll be publishing them soon. But you can see here, there's a sweet spot, 40 to 60% indoor relative humidity, where the GI and the respiratory infections were at an all-time low. So these two studies are good because they show a causation. They show correlation. One of the things we're finding is that the organisms, the bacteria that cause infections in the hospitals are the ones that can survive in the dry environment. So you can see a list of the most common bacteria and how long they persist in on hospital surfaces and in the air. And these are the ones that are particularly resistant to drying. So this is another study that has a built-in control. So a group from the Mayo Clinic in northern Minnesota took a school. They humidified half of the school to 45%. Humidity, let the other half of the building do what buildings do in a cold climate in the winter. The humidity hovered around 20%. And you can see some major differences in the two parts of the school. In the humidified part of the school, there were many fewer particles carrying, this study was influenza, carrying the influenza virus. The actual infectivity of those viruses was remarkably reduced in the part that was humidified. And then not surprisingly, there were fewer kids who missed school due to influenza. So this study has been repeated in 4 other schools with similar results. And I really like this study because it has a very good control, a simultaneous control in the same building. So what we're seeing, and by the way, I do not sell humidifiers. It might sound like I do, but I don't. But you can see that the humidification to 45% improved certain parameters dramatically. Again, this is another study looking at pediatric hospitalizations and indoor relative humidity. I'm not going to go through it, but you can have this presentation and see this slide and see the reference. The bottom line is, again, 40 to 60% relative humidity was associated with the lowest rate of hospitalizations for pediatric influenza and coronavirus. Okay, so let's take a look. What can we do if this person, and this is not me, by the way, somebody asked me if that were me. It's not. If somebody walks into your office or your home and is coughing like this and doesn't have a mask, what are the chances that you're going to get the infection if she's sick? Well, there are really 3 possible places where you can decrease or intervene in the spread of infectious transmission. 1, you can prevent this woman from coming into your house and coughing all over the place. 2, you can try to reduce indoor transmission. So you can try to reduce the transmission through your home or office. And then the 3rd step where you can prevent infectious disease transmission is in the robustness of the secondary host, or how likely are you to get sick. So the 3rd step the vulnerability of the secondary host is something we usually leave up to the medical professionals, like come up with a vaccination, or hopefully you're getting enough sleep, you're eating well, you're exercising, so you're more resistant. But the engineering control is generally through reducing transmission in your built environment. So again, the first step is a behavioral one: social distancing, wearing a mask, locking your door, not letting people in to begin with. The second step here is where we usually focus when we talk about reducing transmission through the environment. And as I said in the beginning, the question of how far this virus spreads through the air has been a topic of controversy, but there's enough research out there now showing that it does spread over significant distances through the air, that we need to contain that route of transmission. So one of the powerful components of managing the transmission is by keeping the relative humidity indoors between 40 and 60%. And our studies are showing that when the air is dry, when you don't keep it in that range, we have greater aerosol transmission. It's harder to clean surfaces because surfaces are recontaminated. And for reasons we don't fully understand, the survival of the viruses and bacteria are often greater in either dry air or air that's has relative humidity over 60%. So just to give you another visual, I'm talking, you're breathing, droplets come out of our airways, 100 microns in diameter, and they rapidly shrink to reach equilibrium with the moisture content of the air. And when the relative humidity is low, meaning less than 40%, the droplets shrink very rapidly. And by the time they reach half a micron in diameter, they have been recovered great distances away and over great periods of time. So let's talk about the impact of humidity on the actual infectivity of the virus. This study is with influenza, and again, on the x-axis you see relative humidity, on the y-axis you see the infectivity of influenza A. And when the relative humidity is below 40%, the infectivity is high. If something happens at 40%, we don't fully understand what is going on with viruses and bacteria. But with many organisms, the infectivity drops dramatically at that level of humidity. And again, with many organisms, it stays low, the infectivity stays low between 40 and 60%, and then it goes back up again. And again, we don't really know what mechanisms are responsible for that. So that was influenza. This is a coronavirus showing the same temperature for all three of these lines. On the bottom, we have days of survival. On the y-axis, we have the infectivity. This is a logarithmic scale. So when the relative humidity is low, or 20%, you have the slowest inactivation, which is kind of, for me, that was counterintuitive. I used to think that moisture in the air or humidity would promote the survival of bacteria and viruses. But we're finding that these organisms evolve and adapt so quickly that when the air is dry, they actually persist in sort of a almost like a spore-like form. And you can see here at 80% relative humidity indoors, you had some inactivation of the coronavirus, but you had the fastest inactivation at a relative humidity of 50%. So again, right in the middle of that 40 to 60% sweet spot, we had the fastest inactivation. So this is the same paper, but showing the effect of temperature in addition to humidity. And what this is showing with the coronavirus, the red line is high temperature of 40 degrees centigrade. So high temperatures, you see very fast inactivation. The blue line shows the rate of inactivation that correlates with a change in relative humidity in a comfortable temperature. So again, 50% relative humidity at the bottom, you have the fastest inactivation at indoor temperatures. The black line shows the sort of slow inactivation when you have cold temperatures. The take-home message from this slide is that no matter what the temperature, you still have the most rapid inactivation in that 40 to 60% range. So, okay, so let's talk quickly about this third column. The column that we usually leave up to the medical professionals or to each of us to take care of ourselves, to keep our strength up. We don't generally think that managing the indoor environment is going to have a big effect on our immune system and on our strength. However, that's not true. The way we manage our buildings actually does have an effect on our immune system. So this is a study that came out about a year and a half ago almost from Yale, where Dr. Iwasaki was wondering, why do we have the flu season in the winter? So looking at all the different variables, vitamin D, crowding, lack of sunlight, why is it that we get sick in the winter? And of all of those variables, the indoor relative humidity revealed itself once again to be the most powerful. And so she was wondering, well, what happens to our physiology, if anything, when the air is dry? So to do this study, she actually used genetically engineered mice that responded the same as humans to the influenza virus. So let's think for a second. If you are in a building and there are influenza viruses in the air, your first line of defense, if you inhale a virus or a droplet that carries a virus, your first line of defense is a mucus layer in your respiratory tract and these little hairs called cilia that are constantly washing upwards. And the cilia, the little hairs floating in that mucus, help prevent the virus from reaching deeper into your chest cavity. If by chance an infectious particle gets past the upper part of your airways, there are other physiological barriers that are designed to protect you. Our body has other cells that come in and try to contain any damage. These cells, macrophages and dendritic cells, secrete proteins that again are very protective for our bodies. They help prevent lung infections. And then they also can activate the other branch of our immune system. But what's really interesting is that Dr. Iwasaki found that when the inhaled relative humidity, the inhaled air has a low relative humidity, all of these steps were impaired, and yet they were optimized at 50%. So you might be thinking, okay, so it makes sense that your mucus in your airways would become somewhat dried out, and therefore the cilia wouldn't be able to move as effectively, which is true. Mucus viscosity is an important component of our respiratory immunity. However, the other steps were also impaired at 20% relative humidity. So think about that when you leave this webinar and you go home and you start reading about respiratory immunity. Think about how the water vapor in the air is impacting your immune system in multiple ways, not just through mucus thickening. So we're finding that this mid-range of relative humidity decreases indoor disease transmission in these two important steps. This isn't brand new information. This is the ASHRAE, an ASHRAE chart from 1985. Again, relative humidity on the bottom, showing that there's a sweet spot, 40 to 60%, where all of these different health problems are the least problematic. And if you take the newer testing techniques and computerized data analytics, we're still finding that 40 to 60% range is where humans are the healthiest and the bad pathogens, the bad microbes are the least bad, and the good ones are more prominent. So again, 40 to 60% we're finding is protective to humans, and it decreases the badness of the bad pathogens, the pathogenicity. So I've just talked a lot about managing humidity indoors. There are other things that we're thinking about. What is the role of sunlight? What's the role of UVC light, bipolar ionization, hydrogen peroxide misting, filtration. These are all strategies that have a role in managing the indoor environment. So just to talk about, I don't have time to go through all those because in our work and in a lot of people's work, humidity is jumping out to be one of the most powerful ways to control the indoor environment. But this is, you can go onto this website for the Homeland Security, and they were looking at the combination of relative humidity and simulated sunlight on viral decay. And here's a screenshot just to show you how you can change these metrics to see what the impact is. So on that website, at the top you have this little slider thing where you can adjust the UV index, you can adjust the temperature and the relative humidity. And what the calculator shows you is a presumed half-life of the coronavirus. You can look at air and you can look at surfaces. So again, this is the website, and you can go on there and check for yourself what different degrees of sunlight, different levels of humidity and temperature do to both surface and airborne SARS-CoV-2. I think I'm getting close to being out of time. So when I look back to Papua New Guinea, I think, why might these people have done so well despite the level of perceivable hygiene in the hospital? You know, for one thing, the indoor and outdoor relative humidity levels were probably pretty optimal. You know, New Guinea's near the equator. The people probably had very robust immune systems. They weren't used to being in environments where the indoor conditions would suppress their natural immunity. And furthermore, there would be no selection for pathogenic microbes. So what do we do from here? By looking at occupant health as a building metric, we've found, for one thing, that relative humidity in that mid-range zone is very important. You know, my belief is that one of the reasons we see this trend is because of how we've sealed up our buildings. You might be thinking, okay, well, what's going on then in Florida? Why does Florida have these outbreaks? One of my engineering friends who lives in Florida goes around from building to building where there's pretty robust air conditioning. And he reports back to me that the relative humidity in these buildings is still low because of the condensing the moisture out through air conditioning. So in Florida, it's almost like you have the reverse conditions. It's hot outdoors, people are going indoors, they're crowding together, so there will be more contact transmission. The air is cooled, which condenses out a good deal of the water vapor. So I think that the indoor humidity, part of the answer is that the indoor humidity is still low, and on top of that, you're having increased contact transmission. So how is COVID-19 a wake-up call? By using occupant health as a lens to view the indoor environment, we've learned how important indoor air quality is. The kind of low-hanging fruit that we're finding now is that low relative humidity during the heating season is harmful to people, and it benefits the bad microbes. So I don't believe we really have a flu season in this country in the cold areas. I believe we have a heating season, and that when we heat and we don't manage the water vapor, we set up a dangerous condition in our buildings. So we really need to pay attention to these trends because there are going to be more. There are going to be more pandemics. There is going to be more influenza season. So we need to really manage our buildings with human health in mind. So thank you. That's my little guy, Luigi, who's under my desk right now. He didn't bark and he didn't snore. So now let's open up to questions and comments. You can have this presentation. Here are some of the references, and if there are any that are missing, just send me an email and I'll provide you with the papers. So
thank you,
very
Dr.
quiet.
Taylor.
You're welcome.
All right, so this is Dev Maharaj, CTTC Chair and President-elect Caricom, ASHRAE Caricom. I have a question here from Paul Onder, and he's asking.
Hi, Paul. I know, Paul.
Okay, so Paul is asking you, Dr. Taylor, how does humidity affect the strength of medicine and the healing of patients?
So could you repeat that again, please? How does humidity affect the healing of patients?
How does humidity affect the strength of medicine and the healing of patients?
I'm not sure exactly what trend you're referring to. Are you talking about the increase in infectious diseases?
Sorry, that would be strength. How strong is it? How does humidity affect the strength of medicine and the healing of patients?
Oh, I see. That's a great question. How does humidity affect the strength of I think of medications and the response? Yeah. It's something I have to think about. But I can say that in general, our studies are showing that when the humidity is low, we form micro cracks in our skin and in our respiratory epithelial systems, which creates an imbalance in the microbes that are processed properly by our digestive tract. So I'm not sure I'm fully understanding the question, but our body is able to better respond to any inflammatory or microbial threat when we don't have those micro cracks. So low humidity is harmful in that way. And when the humidity is excessively high, we have an increase in contact transmission of diseases, and there's some other factor involved that we don't really understand the mechanism of. And Paul, I'm not sure I answered your question, so maybe we can email or you can ask it again.
Hi, this is Julia Rios. Can you hear me well? Hello?
Hi, Julia. Go ahead.
Can you hear me well?
Yes, we can hear you.
Just before.
There's a bit of static from.
Yeah, Julia, you're not very clear. I'll ask the question. This is the one from Tiger Astor. Julia?
Yes, go ahead.
Okay. The question from Tiger Astor. Hi, Doc. I get the bandwidth of RH. However, what's the reference dry bulb in centigrade or Fahrenheit? Or what was the RH if documented, AH if documented?
So
I think ambient humidity is what he means.
Right. So I know that engineers would much rather talk about dew point and absolute humidity. In our studies, the relative humidity, even though that does fluctuate clearly with the temperature, that seems to be the factor that's most important for these evaporative processes. So in this, I think the best way to answer that would be for you to look at the references, because or talk to an engineer about the dew point or the absolute humidity. But again, the outdoor absolute humidity can fall, but it's the relative humidity indoors that seems to be the most related to diseases. So that's a long way of saying I cannot provide that set point for you off the top of my head.
All right, so we have another question from Raymond Bingham. And Raymond is asking, good day. In listening to your research and conclusions, how has localized influence on the environment with pathogens been assessed, if at all? And how do you think it may be influential on the transmission of microbiological media?
So how does the local humidity impact the transmission of pathogens?
How has localized influence influence on the environment? How has localized influence on the environment with pathogens been assessed, if at all? And
I see.
how do you think it may be influential on the transmission of microbiological media?
So I think if I understand your question, how are we assessing the transmission of these organisms in micro environments? And the best way that we have now is using both tissue culture, where we grow organisms like we've been doing for decades, in addition to using the metagenomic analysis tools to identify bacteria and viruses that we cannot grow well in tissue culture. So the air and the surface assessment is done through the metagenomic tools. And I think there are really three ways that humidity affects the transmission of pathogens. One is the number of pathogens in the airborne environment. The second is how infectious they are. And the third is how robust or how good our bodies are at fighting off infections. So those are kind of the three general categories that we use to assess the role of humidity in the built environment. And again, I hope I'm answering your question. I hope I'm answering the question you asked.
Okay, maybe Raymond can give us some feedback. So I have another question, Dr. Taylor, from Gemma Beckles. And Gemma is asking, what would you say are the most effective ways of achieving the 40 to 60% RH range? And then he goes on to say, great presentation.
Oh, well, thanks. I appreciate the encouragement. You know, I am not the right person to ask about how to humidify because it depends on your temperature, your outdoor temperature, indoor temperature. In a hot, dry outdoor climate, evaporative cooling gives you the extra benefit of humidifying. I know if you want very careful control, steam humidification is appropriate. In some settings, you actually need to dehumidify. So if you're finding that you're over 60%, you need to actually withdraw some of the water vapor. But unfortunately, I'm not the best person to answer the question of how to do this. I am just telling you how important it is to be aware of this mid-range humidity zone. That's where your expertise as building professionals comes in.
Okay, I have a question here from Charles Frost. And Charles is asking, what is the current humidity requirements in healthcare facilities? I guess that's part one of the question. Maybe you can take that part and then we go to the other part, Doc.
So Charles, that's a great question. And unfortunately, in some countries such as Japan and Malaysia, 50% relative humidity is the design guideline. In the United States, in Canada, and in Europe, the only spaces that are really regulated are the operating rooms and the sterile supply rooms. And in the operating room, ASHRAE is several years ago dropped the minimum relative humidity level to 20% based on surgeons and clinical staff wanting it to be cool because they have many layers of sterile gowns on. But then we began to discover this about the humidity, that 20% relative humidity is harmful for the patient. So now ASHRAE is working to raise the minimum humidity level to 40%. So hospitals in the US, we're doing it all wrong still. Patient rooms aren't even monitored for the most part. Sterile supply rooms are probably the safest spaces because the minimum humidity has to be 35%. And the reason for that is that the masking tape that keeps the blue paper down becomes unstuck if the air is too dry. So we're not managing humidity for human health in hospitals. Unfortunately, we're working on it. I will say that an encouraging sign is in that I'm on the epidemic task force, and for school reopenings, the design guidelines for indoor relative humidity are now 40 to 60%. if that can be done safely given the building envelope. So that was the first question, I think.
Right. I think you got both parts of that question, Doc.
Okay.
So we have
Can you hear me now?
Hi, Tulia, go ahead.
Do you hear me better now?
Oh, sure. Yes,
Yes.
go ahead.
Okay. So we have a question from Ronaldo Jalil. What IAQ recommendations do you have for tropical island countries with ambient relative humidity of 80% throughout the year to help prevent the spread of COVID-19?
Yeah, I mean, I know I'm presenting to a geographic area where low humidity is less of a problem than high humidity. And I think with those conditions, if your ambient relative humidity indoors and outdoors is 80%, then you have to work to bring it down indoors, whether it's through cooling, increased ventilation. Again, I'm not primarily an engineer, so I would just say two things. One, pay attention to the difference between the indoor and outdoor conditions, because it's really the indoor conditions that matter. And if you can't bring it down, then be particularly attentive to things like surface hygiene and decreasing contact transmission in buildings where the humidity is over 60%. But do what you can to reduce the indoor humidity. I wish I were an engineer. I could answer some of these questions better.
Yeah, and I think more and more engineering questions, as I go through the list, Doc, I'm seeing a lot of engineering type questions. But we'll take a shot at it. From James Bogart. How important is the method of dehumidification? And he goes on, I've heard many recommendations to use steam, but are other methods such as evaporation, atomization acceptable?
Well, so I can answer that to some degree. If you have direct steam humidification, you have to be very careful about other chemicals that might be in the boiler or the container, because you don't want to be releasing sulfur, nitrous, or nitrate, or other volatile organic compounds into the breathing zone. So that my general rule of thumb is if you can drink it, then you can humidify with the water. So direct steam humidification has to be done very carefully. Evaporative humidification, you can't really do that unless you generally have dry conditions in your building. Atomization is fine, but just make sure that you clean the humidifiers so that you're not aerosolizing any biological compounds that can make you sick. I personally like the evaporative systems. Again, I live in northern Vermont, so in the wintertime, I will accept a little bit of cooling, even though it's already cold out, in exchange for the low energy requirements of evaporative humidification. So I hope that's a helpful answer.
I have another question.
Go ahead, Julia.
Okay, we have a question from Antoinette Johnson. She says, in the Caribbean, we have seen low, I'm sorry, I lost it. Hold on one second. In the Caribbean, we have seen low rates of COVID-19, high cost of air conditioning, and high outdoor relative humidity, especially in summer, means that we are in that sweet spot you mentioned usually, but for different reasons. Do you think this could be the reason for our low rates?
Yes, I do. I definitely do. And so I'm involved in a big study at MIT, Massachusetts Institute of Technology. We're looking at all of the different variables that we can gather since mid-December. So we're looking at indoor and outdoor climatic factors. We're looking at government interventions. We're putting all these data points into a massive analysis using machine learning. And of all of these components that are related to new COVID deaths, and I promise you I'm not just making this up, low relative humidity is once again one of the most powerful factors that is related to increased transmission. So I do believe that the reason you're seeing lower incidence is because you have a good indoor relative humidity. And you're really lucky. I mean, I'm happy for you.
Yes, indeed. I have a question here from Heather Taylor. Has there been any efforts to control humidity in laminar flow over operating tables to reduce the risk of surgical site infections with increased humidity?
Yes, Heather. I mean, that's a great question. Yeah, that's a really good question. Yes, there are some forward-thinking hospitals that are increasing the relative humidity in the operating room to 40%. And thankfully, they're seeing a reduction in their surgical site infections. I can point you to some of those studies. If you'll have this presentation, you'll have my email, so I can send you the studies. But we're finding that you can actually turn down room air changes in the operating room when you keep your humidity between 40 and 60%. So you're saving energy by reducing room air changes in that zone, and we're seeing better surgical outcomes. It'd be great to do a study down in your region, so where perhaps the indoor environment of a hospital is closer to the 40 to 60% sweet spot. Be great to do a study to compare to other regions.
Yeah. Julia,
We have another one. Yeah.
Okay.
Yes.
Go ahead.
We have a question from Andres Aloma. He's from Miami. He says, you mentioned bipolar ionization and photocatalytic oxidation earlier. I wanted to get your opinion. You being a medical professional, what is your opinion on the effectiveness of bipolar ionization?
So I have not reviewed carefully the studies at a level that I would like to before I can really be clear about my opinion about it. I think in the short term, these strategies have been found to decrease the number of infectious virus and bacteria in the air. I have some concerns that using both light or anything that involves an oxygen radical or excess of hydrogen ions, that I get concerned that bacteria and viruses over time can develop resistance to those technologies. But I think that if they're used periodically and carefully and in the right areas, they're, as far as I know, very beneficial. But that's not something I can really comment on with a lot of expertise.
Okay, I have a question from an organizer, not named. Will sunlight destabilize or stop the spread of COVID-19? And this is a question from someone in Trinidad. So he's saying, in Trinidad, we have a high temperature and our humidity varies throughout the island. So will sunlight destabilize or stop the spread of COVID-19? Is the question.
So I think sunlight definitely has the ability to decrease the infectivity of COVID-19. Sunlight alone is not going to decrease transmission as much as sunlight in addition to proper humidification. But if you go to the Homeland Security website, you'll see not only that calculator that I showed you, but you'll also see a recent study done by NIOSH where they actually look at simulated sunlight, different temperatures, different humidities, and show that the combination of sunlight and 40 to 60% is the most effective in decreasing transmission. So I certainly think it's going to help.
I have actually a comment for you from Ashsaki Chowdhury. I'm sorry, I probably butchering the name. I'm sorry. He says, this person says,
The 2018 school-based study considers only the hours the students spend in the classroom. Those students spend many more hours outside of the classroom. As such, the results may not be complete representative. That was a comment.
That's talking about the preschool study?
Yes.
Yeah, I mean, you're right. That's absolutely true. And that's a great point. Interestingly, the GSA, the General Service Administration that manages all the federal buildings in this country, found that in some of their buildings, the people were tired and stressed out all the time. So they did a study looking at productivity and looking at cortisol levels, which is a sign of stress, as it related to the indoor environment. And once again, they found that low humidity was related to higher stress, higher fatigue, and higher cortisol levels. Furthermore, they found that at night, when these people went home, that their quality of sleep was worse when the air was dry during the day. So we now know that the effects of dryness on your skin actually causes an increase in cortisol, which interferes with your immune system and your sleep, even when you're not in that environment. So you're right, those children obviously aren't in school 24 hours a day, but we're finding that even 6 or 8 hours a day of being in a dry environment results in higher cortisol levels, which is not good. Something's happening on my computer. Oh, not mine.
Okay, so we have a question here from our very own Ian Weeks, chairperson of Government Affairs, ASHRAE Caricom. And Ian is asking, Dr. Taylor, thank you for an excellent presentation. In the Caribbean, most of our countries and islands are normally very humid. Therefore, we have a battle with constantly trying to effectively dehumidify the air. As a practicing industrial hygienist, we find, and that's Ian, we find that relative humidity at approximately 45% is unfavorable for the survival of mold and microbial growth. So our takeaway from your presentation is to maintain 45% RH to keep indoors unfavorable to microbial and microorganisms. Thank you. So I guess it's just a comment, not a question.
That's great to hear. I think
Yeah.
I'm going to move to where you live.
Yeah, please. It's paradise.
Me too. We have a question from Diego Pon. He's saying, what architectural features do you recommend to minimize infectious transmissions?
You know, I think as we begin to really use occupant health as a building metric, there are going to be changes in several aspects of building space designs and in the, you know, for example, in the ability, at least in a cold climate, the ability of a building to contain proper humidification. So there could be implications for the building envelope to avoid thermal channels in the wall. In your part of the country, I think that one of the changes that we may see is the use of building materials that have micropores, so stone, brick, wood, so that you can actually have the structural materials begin to modulate the indoor water vapor, in addition to either adding or subtracting water vapor directly. So I think as hopefully we understand that we need to have a mid-range humidity in buildings, so the building materials themselves will be modified to help keep that good range. But that's a great question. I'd love to talk more with you about that.
Thank you.
Okay. Question from Antoinette Johnson. And Antoinette says, in the Caribbean, we have seen low rates of COVID-19, high cost of air conditioning and high outdoor RH, especially in summer, means that we are in that sweet spot you mentioned usually, but for different reasons. Do you think this could be the reason?
I asked that one already.
Oh, you did?
I do,
Oh.
yeah, I do think that's why you're doing very well. And, you know, if you also look at influenza, the seasonality of influenza disease, countries that are closer to the equator actually don't have the same highs and lows as temperate conditions, as temperate areas such as, you know, Chicago or where I live. Doesn't mean you don't have any influenza or any COVID, but the transmission, it's usually reduced, and the root of the vector is more often contact transmission, which is actually easier to manage than airborne. So that's just a little bit of additional information about the pattern of infectious diseases as you get closer to the equator.
We have a question from Alvin Daniel. Hello?
Hi.
Can you hear me?
Yeah, we hear you.
Okay.
Yes.
We have a question from Alvin
yeah.
Daniel. His name, he says, based on what Dr. Taylor says, should we now consider making it mandatory that humidity controllers be installed along with thermostats?
Absolutely. I wish you could take that message to every Ministry of Health in the world, because I think we would have fewer infectious diseases. I think we'd have fewer inflammatory diseases, which is related to heart disease. So yes, I think humidification should be as important as temperature control. Unfortunately, we don't have sensors in our skin for humidity like we do for temperature. So I think because we don't feel it constantly, we tend to forget about it. Plus, there are challenges in some climates with keeping indoor humidity. But short answer is yes, I wish that would happen, and I look forward to it happening.
Okay, question from Nafisa Ali. Hello, thanks for a wonderful presentation. In light of many companies providing sanitation services, and also in Caribbean countries where COVID-19 testing is limited and expensive, what surrogate microbiological tests can you recommend that our other labs can effective sanitization was completed?
Wow, that's an amazing question. That's a great question. It's so good, I'm like totally startled. So there are surrogate tests to look for microbial activity that don't require like the metagenomic test for COVID-19 per se in the environment. Even particle counts in the small 2.5 micron and less, particle counts in the air are a good surrogate for viral transmission. There are other techniques like ATPase wipes, where again you can look for microbial activity, and it's less burdensome than looking for COVID-19 per se in your environment. And so those are great ways of seeing if somebody has brought a virus into a building. And so if you don't have robust human testing, or you don't have robust ability to detect COVID-19 in your environment, these other surrogate measurements are definitely useful. So ATPase wipes, particle counters are just some of them. But that's a great question, and that's something I'm working on in my new company.
Are you there, Tulia?
What?
All right, so I'll go ahead and ask a question posed by Gustavo.
I am.
Hope I got that right. Hello, doctor. In an architectural sense, what can change in the design of hospitals to prevent spread of diseases? From an architectural perspective.
Yeah. So I think some of the strategies that we already think about, such as single rooms or putting fewer people in one room, maintaining good surface hygiene in the bathrooms, having negatively pressurized toilet areas so that you don't have aerosolization of different pathogens such as, well, COVID-19 is found in toilet water, Clostridium difficile. So having negative pressure in the bathrooms, having good surface hygiene, having building envelopes that are adequate for maintaining indoor humidity. I actually think, and this goes against the Facility Guideline Institute in our country, I think that if you're in a building where you cannot adequately humidify all the indoor spaces due to, say, a cold outdoor climate and condensation in the building envelope, then the more vulnerable patients should be put in the center of the building, in the core, where you can safely increase the humidity to that sweet spot. Right now, everybody wants views of nature, which are wonderful, but if you're going to not heal as well, if you're going to get an infection because a room close to the building envelope can't be adequately humidified, I'd rather go home and have views of nature than see nature in the hospital and not get out alive. So I think that properly constructed building envelopes and smaller spaces, appropriate pressurization, and maybe having a variable use of the rooms are all strategies that will help diminish infections.
Okay, I'm seeing a second question here from Heather Taylor.
You want me to read it?
Yeah, go ahead, Julia. Go ahead.
Okay. So Heather is asking, does the ideal relative humidity reduce the time it takes for the pathogens to fall to the floor? The standard time it takes for the environment team to be able to clean COVID spaces is typically 1 hour. Would the relative humidity need to be taken into account per each hospital by monitoring in order to correctly adjust the time before EVS cleans a space?
Oh my gosh, absolutely. If you could actually time environmental services according to the indoor air characteristics, that would be brilliant. So yes, I think those two parameters should be correlated and could be, and you could potentially save save ineffective cleaning if you do tie together the indoor humidity and the cleaning, the timing of the environmental surfaces. That's actually there are amazing points being brought up in this in these questions.
Same person is asking, is outside air a significant variable as well, in addition to the relative humidity of the space to reduce pathogen transmission?
Yes, I think outdoor air is very beneficial. I think again, I know where you are, I believe the outdoor temperatures are generally closer to being comfortable than where I live, but outdoor air ventilation is very beneficial. Where I live, if we have 100% outdoor air ventilation, the cost to heat and humidify a building would be exorbitant. So I think depending on your outdoor climate, you have to find a balance between recirculating indoor air, bringing in outdoor air, and the costs of heating and humidifying. But I feel strongly that we cannot forego humidification in exchange for all outdoor air. But the more outdoor air you can bring in and still manage it correctly inside, I think the better, unless you live in Beijing or someplace where it's highly polluted.
Question from Richard Gunbat. And Richard is asking, would you recommend an indoor RH up to 60%, sorry? Does this contribute to lower energy consumption of AC equipment versus a lower RH of 40%? Which is better, 40 or 60%?
I think I'm going to have trouble answering that because it depends on the temperature of the air coming in. So in terms of the safety, 40 to 60% is all a very beneficial range. So again, I feel like I'm a little bit out of my area of expertise because it seems like an engineering question.
Yeah,
But
it sounds like an optimization question for energy consumption.
See, if you would invite me to come back in person in a year, then I could turn those questions back to people in the audience to help.
That would be great.
Yeah, it's always tough.
Well, maybe some
When people start asking me about the psychrometric chart, I don't like it.
well, maybe some of the people that are here in attending might be able to answer some of those engineering questions.
Exactly.
We have a question from an organizer of this session. Dr. Taylor will. I'm sorry. Oh no, I'm sorry. That's not a question. We have a question from Tiger Astor, and he's saying, Doc, question 2, why is no one talking about loosening up the buildings with appropriate technologies that can regulate temperature, humidity, and outdoor efficiency?
I like this question better, Tiger, than your first one about the dry bulb. You know, I don't know. I believe that the disconnect between the medical professionals and the engineering and construction architectural services is so vast that, again, this is just my experience. Often when you talk about humidity, engineers hate you. They think of condensation in the building envelope. They think of liquid condensation. They think of mold. But that, I believe that COVID-19 is going to help change people's attitude about the importance of indoor humidity. But Tiger, you ask good questions and email me and I can give you more information outside of an ASHRAE presentation on some of the work I'm doing to move in that direction.
Tulia, you have another question?
Okay, I have Ian Wikis. He's saying in the Caribbean we have constant flows. I'm sorry?
Yeah, go ahead. Go ahead, Tulia. Sorry.
Okay. In the Caribbean, we have constant flows of African dust. Do you know of any studies that speak to the negative or positive of dust particles on reducing the or increasing the outdoor relative humidity?
So when the outdoor relative humidity is low, we see higher particle counts. And there was a study that came out of the Harvard School of Public Health in June that correlated higher indoor particles with increased transmission of COVID-19. But the variable that connects particles and transmission is the relative humidity. That's what this study found. So generally, when you have higher humidity in the good range, you have lower airborne particles. And sorry, I think that was your question. You know, I wish the platform were different so that I could ask, you know, the participants questions, because these are really good thoughts.
I'm going to try and make that happen. Give me 2 minutes.
Wow.
All right, so I have a question here from Javi Morocho. Is best the ozone that UVC in high countries with okay.
I think that what he's asking is
the ozone that UVC in high, yeah.
What I believe he's asking is the ozone ozonization the best solution with UVC in countries with high relative humidity? We're struggling with a language barrier here, so it's a very it's hard to understand exactly what he's asking. Maybe yes. Javier could ask the question again.
Or he could ask it in Spanish and I could translate if that's okay. If that person wants.
If Javier, if you could ask the question in Spanish, Julia will translate. Deb, okay. You want to ask Raymond's question?
Okay.
Just one thing. When Deb is finished, I will unmute all participants, all the attendees, and please mute when you're not asking a question so we can make the session a little bit more interactive for Dr. Taylor.
Wow.
Okay, so Raymond Burnham asked, what time period of exposure to the virus is crucial for transmission? For example, RH indoors may increase or decrease out of the sweet zone, and due to that may increase the level of transmission. What operating range of systems is feasible in terms of variable RH? Yeah. What operating range of systems is feasible in terms of variable RH?
So I think the question is, what are the allowable excursions away from that sweet zone? How far can you deviate from that zone, and for how long before you begin to see adverse health effects? And that's actually another really good question. If you look at the studies of the cells that line your airways, you begin to see cell damage in about 15 to 20 minutes at 10% relative humidity. Most of the time, at least ASHRAE standards are more concerned about exceeding the higher level of relative humidity for reasons having to do with condensation. But depending on which of the factors of transmission that you're thinking about, it would be different amounts of time. But based on studies in airplanes, I would say that, and again, this is just my assessment of the research, that really within about an hour, you begin to see adverse effects from low relative humidity. You would begin to see adverse effects from high relative humidity on the building envelope or on the building, depending on how it's constructed. So I think you don't have to maintain that sweet spot minute to minute, but over the course of a day, if you're outside of that range, especially on the low side, for more than an hour or two, you're going to begin to affect the health of the occupants.
Dev, Tulia, is that all the questions that you all have for now? I would like to open up the discussion, if that's fine with you all.
Go ahead. We have like about 5 or 6 minutes, so go ahead and do that, Hiram.
So
just reminded.
If people could, if the engineers could talk to each other and answer some of the questions that I am not knowledgeable enough to answer.
Cool.
We have.
Was that to you?
Sorry, we have one more question from Peter Thompson.
Okay,
oh,
no
a comment actually. He's giving a comment. He says, in the Caribbean, as discussed by others, we have high humidity issues. As an engineer, I have always believed that we should deal with the humidity before the outdoor air enters the building. This has not been welcomed by developers and property owners. This needs to be changed, and we need to get legislation standards to have that implemented.
Okay, so Karen, you could probably go ahead and open up the floor to everyone.
So attendees, you would be able to unmute your mic from your control panel and ask your questions to Dr. Taylor. We'll open up the floor for 10 minutes and then we will call the session to close. Once that's good with Dr. Taylor. We have a question?
Yeah,
Comment?
good evening. It's Peter again. I wanted to expand on that a little further. The comment that Tulia just raised or just mentioned. So I'm an engineer, doc, and too often we allow high humidity to go into a building by just using outdoor fans. And I liken it to something else that I heard at an ASHRAE seminar many years ago. If we are wet, suppose we came in from a heavy rainfall, you're very wet, you're soaking, your shoes are muddy, you don't walk to your front door, walk all through the house, through every room, and take that moisture and mud and everything else into every room, and then try to clean it up afterwards. I am of the strong belief that we need to get building owners and developers to be willing to spend the money to deal with the humidity before we bring it into the building. In other words, any outdoor air which is supplied to the building should be controlled. Once you control the humidity at that point, in terms of the internal control from other, whether it be the occupant or other devices which will raise the humidity, that is a much easier control mechanism inside of the building. But I think we need to get to the stage where we are designing buildings with outdoor air which is already treated, so that once we introduce that air into the building, you don't have high humidity to deal with, and then also the humidity which is generated by occupants and other devices. That was my comment. And thank you for a great presentation. That was an absolutely wonderful presentation. I thoroughly enjoyed it.
And just a reminder that you can unmute your mic and ask your questions to Dr. Taylor. This will remain open for the next 7 minutes. To ask any questions, you can feel free.
I'm just wondering, is Javier still there? Javier Morocho?
I am looking right now to see if he is.
In the meantime, Dr. Taylor, I'll ask a question. How have engineers in the US responded to your research? And has there been any sort of uptake of the recommendations? Hello?
Dr. Taylor, your mic is muted.
Oh, thank you. So how people responded? It's interesting. I've seen sort of not too many people are neutral. Your group has been very open-minded and I think has embraced this concept. Some of the ASHRAE members who have been focusing on decreasing moisture and who aren't familiar with the newer metagenomic analysis tools can be very much against managing humidity in buildings. So it really depends on how in my opinion, how open-minded engineers are. But for the most part, people embrace this concept, and we're beginning to see movement towards humidification management. Although there are some very outspoken engineers who don't like the idea. Oh, the other thing I wanted to mention. So there's a big, the UVC industry is very prominent, and I think UVC definitely has benefits. However, when you humidify, you have to make sure that your ultraviolet C intensity is within spec. So if it's a little bit low, if your bulbs are beginning to wear out, and you're humidifying, you're going to have even less UVC transmission. So people, engineers who tend to think in sort of on or off, right or wrong, if they endorse UVC, they tend to be against humidification. That's a very big generalization, but I've seen that sort of polarization of opinions.
That's interesting because our battle here is with dehumidification.
Right.
So we fully understand what you're saying. We don't struggle with low humidity unless it's a server room, where they generally, you have very little external influence from moisture, and it's just machines operating. But so in an office environment, we are always struggling with humidity, high humidity, and the cost of dealing with that is significant.
Yeah.
Which is why Peter's comment is very, very representative of our region, in that the owners will tend to either not want the dehumidification or instruct their maintenance persons to turn it off because it's costing a lot. What I'm seeing as an opportunity now is, with COVID, building owners will have to manage the environment much more closely. And this information that you've presented tonight is further justification for doing such and ensuring that humidity levels are controlled. We struggle with mold, we struggle with indoor air quality issues, and a lot of them are related to humidity levels.
Yeah. I know your challenges are very different, but again, I think saving costs on the building at the expense of human health and human lives is not a good trade-off. So the challenge is, how do you present a return on investment, a business model to building owners that actually shows the, you know, the value of a healthy human being, and that's challenging.
I'd like to make a contribution. One of the problems that I see both in the United States, I live here in Miami, but I'm from the Caribbean, Trinidad in particular, is the exact opposite of what people are focusing on, which is there's a low humidity problem that we are suffering from because of the fact that in Miami, I would think there's 90% of the homes do not use outside air. And when the unit runs continuously, the humidity level drops significantly low. I've questioned a lot of people who tell me they wake up every morning with a dry throat. And that is proof of what is happening. And even in the Caribbean, most of the homes do not add outside air as a means of bringing fresh air into the home. Everybody's thinking of the commercial side, where we normally add 10 to 15% of outside air. But what about the times when the sun load is not as high and you get very low sensible heat? Then you have a different problem now, where high humidity over 60% becomes a significant problem, just as you pointed out, Doctor. So I think the whole question of how we calculate and how we regulate has to be revisited to control it and keep it between that 40 to 6%. I could go into a whole treatise on the psychometric chart and how it affects that percentage. But yeah. I see the bigger problem of a lot of homes and buildings having no fresh air whatsoever to give you that, at least some sort of humidity into the building. And of course, despite all the calculations we do, if you're not monitoring the humidity level, how can you know if you're getting it? I'm the same person, Alvin Daniel, that spoke about the need for mandatory use of humidity recorders in a building, at least visual. And I've been preaching this for a little while, and I'm very, very happy to see today. But I don't want to take any more time, but that's my little input. Thank you.
So what is your name?
Alvin Daniel.
So will I be able to get your email? Because I would really like to correspond with you.
I will send it to the powers that be, and they'll pass it on to you.
Okay.
So, we do have Alvin's email address. He's actually an ASHRAE. Alvin, what's your title? Life member. And he was present at our inauguration, so we do have his contact details.
I mean, at the very least, if people started putting hygrometers in their occupied spaces, we would begin to measure humidity. But it's off of our radar because we don't sense it easily. But I would really like to talk with you more, Alvin.
Well, I hope they pass my email on to you, and I'd be happy to discuss some of the thoughts that I have on that. I've been doing air conditioning now for over 50 years, so I have a lot of thoughts about it.
That would be great. And I've been engineering, a colleague who's an engineer in the western part of Florida, and he's the one who goes around with a hygrometer and reports back these low indoor humidity in highly air-conditioned buildings. And he has some very interesting perspectives that I think you would. His name is Lenny. I think you and Lenny would have an active dialogue, and I'd like to be a part of that.
Okay, thank you. And thanks for this. This was like really a revelation. Thank you so much, Doctor.
Well, thank you for all your great questions. This is a wonderful chapter, or 2 chapters here.
I need to join the Miami chapter as well.
I think all the humidity down where you are makes people more open-minded.
Yeah. Can I just add a comment there?
Lucy, can you hear me? This is Julia.
It's a little bit tough with the echo.
Hello?
Okay.
I'm sorry.
Is there?
Want to thank.
Hello?
Yeah, it was a great presentation. Thank Dr. Taylor.
Thank you very much. This has been a really wonderful group to talk with.
I will most probably mail some things to you. Thank you so much.
Thank you very much. Have a good evening.
All right. So on behalf of ASHRAE, Caricom, and the Miami chapter, I would like to thank Dr. Stephanie Taylor for taking a valuable time out in preparing and presenting a very enlightening session for us this evening. It is Monday evening, and I would like to thank our wonderful audience for your participation, your patience with us through the technical difficulties. And I would like to thank our man behind the scenes, Kyron Nanan, for once again, holding the fort for us. On behalf of the president of ASHRAE Caricom, George Nicholson, I would like to thank you again, Dr. Taylor, and I hope to see this wonderful participation as an ongoing norm. We will be publishing our upcoming CTTC seminar for September, and again, we look forward to this great participation. Thank you all, and good night.
Thank you very much.
Thank you.
Thank you, Dr. Taylor.
You're welcome. Thank you all.
Cool, no problem. I'm going to end the session now.